So, you want to be an ICU nurse. Little do you know that you're in for the ride of your life.
1, 2, 3, funk it.
Hey friends, it's Trish and I'm back with another video, and today I'm going to be sharing with you my new grad ICU tips that I wish I knew when I was brand new. I remember the first day I came in and I was like, alright, let's get this spread, we gonna do it. And then when it came time to actually getting started, I was like, I just was intimidated because I didn't know how fast-paced the ICU was. So I've broken this video down in two different ways. The first part is going to be some clinical tips that I wish that people had told me, and then the second part is just overall ICU tips. If I had to say one overall thing, it would just be to come in with an open mind and come in ready to learn. And honestly, that will make you the most successful as you transition from student nurse to registered nurse. Tip number one, just get ready to jump in at any time. It's definitely good to be over-prepared for your first day in the ICU. So read up a little bit and practice some skills that you haven't done since nursing school. If you've been a little rusty and you've been out of it, you may think that your first day is just an observation day or that the nurse is gonna do everything for you. And yeah, that was true when you were a student, but now, girl or guy or whoever you are a registered nurse. You got your own license, you're in the game.
I'm ready.
Your preceptor may throw you in at any time, and that's not to say that they're always gonna let you drown on the first day. You may have to release the blood for the blood bank, grab it, prime it, ask someone to read with you. Or they may ask you to do something like grab your own meds from the Pyxis and they may not follow along. Show them that you're confident and that you can do it. However, with that, if there is a time at all where you feel like, I really don't know, just ask the question, because at least they know where your thought process is so they can trust you a little bit better. Sometimes what you can also do is you can say, hey, I remember that when I was in nursing school, to prime the blood, I usually have to grab a saline, prime the tubing, and then let the blood run through after. Can you just verify with me if that's correct? In the ICU, you're gonna get alarm fatigue. There's IV pumps, there's ventilators, there's other machines like continuous dialysis machines. Everything in the sun has an alarm, and you wanna familiarize yourself to the sound, because as a new grad, it's so easy to get caught up in trying to chart and get everything done that you'll forget that you're trying to listen out for your patient's IV pumps.
Write that down, write that down!
And sometimes those medications are things that should not be stopped. Make sure your alarm parameters are set for your O2 sats, your heart rate, your blood pressure parameters. Don't worry if you can't do it all on the first day. Your preceptor will remind you about these things. Ask if you can pause any drips. If you're trying to be helpful, or you hear an alarm go off and the bag looks like it's almost empty and you don't have a bag at the bedside, then I would ask your preceptor if it's okay for you to pause a drip, because sometimes you don't know if those are medications that really need to stay on, things like pressors, or if you've ever had Flolan for pulmonary hypertension, then those are things that you need to make sure that stay on.
Never ever? Never, ever, ever.
You never know how fast your patient can decompensate, especially if they're really sensitive to the drugs. Just make sure that you have extra bags for volume, or let's say your tubing's expired, you can prime a whole new setup so that you don't have to pause the alarms. What I like to do when I have medications is I never put the full volume of the bag in. So let's say I have a 250cc bag, then I'll put it for like 220, just so I have that 20 cc's of room to call the pharmacy just in case I don't have a new bag waiting for me as well. Let's talk lines. So with lines, you always want to know what sort of access you have. You'll get asked that when you go on breaks or things like that. Or let's say something emergent happens to your patient, you're gonna get asked what access do you have. So make sure you know if you have a central line or a midline or an IV line and what gauge it is, just so you know what can flow through there. You may think, oh, I have a central line and that may be good enough to run blood, but really if you have like a 16 gauge in their arm, it may be faster to run blood through there than it is through the port that's in your central line. Ask and find out what the goals are in your unit in terms of the patient. For example, something that's used across the board in many ICUs is the MAP, or the mean arterial pressure. In the standard textbook definition, it's mostly 65 or greater, but when you work with certain populations, they may want it higher. So in my ICU, we like to have our MAP 70 to 110. Just like our platelets can be really low, you may look at a platelet and you're like, oh my god, platelet of 50 is really low, but chronically, patients in my population can get platelets as low as 20. And so sometimes, because we know that they're gonna eat the platelets up, we don't really transfuse them unless they're symptomatic. It's different per institution, but just make sure to ask and know what the unit standard is for those certain things. Make sure that you check your patients over your alarms. You know, your patient could be brushing their teeth and then the alarm's reading VTAC.
It's just my imagination again.
Also on the inverse, even if your vitals look good, but your patient is looking really crappy, that may be a sign that they're headed downhill. And trust your gut, and if something is telling you that something's going wrong, relay that to your preceptor or relay that to an older nurse. Ask your preceptor if they don't tell you what it is that they think you did well and what it is that they think that you need to work on, and compare that with how you felt that you did for the day. And make sure you take that into account and you really practice the things that they told you to work on. It could be something as simple as time management. It could be something that is more of a clinical skill. Some of them are just skills that require time, like the time management, but it could also be like, are you doing things very slowly? Are you getting so behind that at the end of the day you're trying to play catch up?
3 hours later.
Really try to get ahead of the game, because that could be really detrimental in the future, and that you may not be able to get the things done when you have not only one but more than one patient. Take care of yourself. Honestly, it's a really hard transition from school to new grad, and it really takes a lot of your time to become comfortable and be fully in that space, feeling confident. It can take you almost the whole year, if not 2 years. And try not to take things personally. If your preceptors are letting you drown, I think they do it out of a place of wanting to see you succeed so that you will never make that mistake again. At least that's what my preceptor told me. If it's getting to be where you're feeling bullied, definitely talk to your nurse manager. And ICU is already really heavy enough, and you want to be able to last as long as you possibly can. So you carrying all this extra weight will not help you to stay long. It's not all on you. It's not. Make sure you ask for help where it's needed. If someone offers their help and you need the help, please, by all means, go ahead and accept that help. Delegate to your CNAs if you can't get something done, and don't try to do everything by yourself, because it's all about working together as a team. I know it's not like that in every ICU. It really makes a difference in the culture if you promote that teamwork. Not only will you feel supported in scenarios where shit hits the fan, but you'll feel supported in normal scenarios. Learn how to page doctors in an efficient way.
There is no way.
So this is actually my favorite tip that I learned from my preceptor. When I page a doctor, I try to be super specific, because you don't want them to yell at you. Know that doctors don't have a lot of time and they have a lot of patience. They just want whatever's brief and whatever's important, because they have other people that they need to see. So when I page a doctor, and you want to be as specific as possible. So I'll say something like, Smith, bed 5, FYI, patient temp 38.5, hypotensive, map of 40, patient looking septic. I'm gonna initiate the nurse sepsis protocol. Can you order antibiotics and do you want a fluid bolus? And then after I've sent that page, then I'll document it on my end and make sure that you follow up. I will specifically tell them which orders to write if I can, so that it saves them some time and they can just be like, oh yeah, that's what the nurse needs. The same kind of goes for when you give report. Obviously you're trying to give an overall picture. Let's say I was talking to a doctor, I wouldn't necessarily say things like,
the patient had poops, the first one was brown, the second one was green, and the third one was large and yellow.
I'd be like, did the patient poop? Yes or no? Was it melena? Yes or no? And if not, then you move on to the next thing. Try to be really intentional about the things that you say to a doctor. And overall, just come in with an attitude of excitement. You'll have a bunch of up and down days. Ask questions and be open to experiences of learning. Don't be cocky. You will get through it. You will get through the first year, and I promise you it'll all be worth it. I hope that this was helpful for you. If you have any questions, please drop it down below, and don't forget to give this video a thumbs up and subscribe for more ICU videos. All right, thanks guys. I'll see you in the next one. Bye.